Hello, welcome back to Integrated Clinical Vignettes with Dr. Carlo Raj. Our discussion will now conclude with our answer choices with the previous patient we had who was 74 years of age who was suffering from atrial fibrillation. If with atrial fibrillation that we've talked about, this patient is now predisposed to developing thrombi. Of all the chambers in the heart, it would be the left atria that would be most likely to develop the thrombi, hence embolization. Thus, the patient must be receiving warfarin, must be put on a blood thinner. Warfarin would be the most effective, statistically speaking, blood thinner out of the hospital, in which it prevents the likelihood of a stroke from taking place. Warfarin is a drug in which you would then use PT-INR, that prothrombin time, 11 to 15 seconds. When you're dealing with warfarin, you know that you're dealing with the extrinsic system of the coagulation cascade. That PT with extrinsic would mean that it's beginning with the factor 7. Tissue factor. It is vitamin K dependent coag factors that you're paying attention to, specifically 2, 7, 9, 10, slash, and I'll tell you why the slash has been placed here strategically, protein C and S. That slash has been placed, and many of you already know as to what I'm getting at, because of the differences that exist between the two groups. 2, 7, 9, and 10 would be procoagulant. C and S would be anticoagulant. Naturally occurring in vivo, all coming from the liver, vitamin K dependent, the enzyme epoxide reductase. Next, when you're dealing with protein C and S, you want to keep in mind that the most important factor that it's responsible for normally eliminating would be factor 5. And factor 5 becomes very important for you clinically because factor 5, if it undergoes a particular mutation of a glutamine, substituted at position 506 with arginine, then you have now created an immortal factor 5 known as factor 5 laden. And you know that being the most important and the most common of all of the genetic hereditary thrombophilias or hypercoagulable states. So that's a little bit of protein C and S. Let's continue with the discussion of warfarin. Let's go ahead and start talking about complications. The complications for warfarin, obviously bleeding. If it gets to a point where you have supratherapeutic type of INR in national normalizing ratio, you're always worried about your patient bleeding. Skin necrosis. Understand the following. You're giving warfarin. Okay, what does it do? Inhibits enzyme. Where? In the liver. Epoxide reductase. Well, what factors are you knocking out? Vitamin K coagulation factors 2, 7, 9, and 10. Understand that when warfarin has been given, that it will initially cause a drainage of protein C. If protein C becomes drained initially, with a very short half-life on top of that, then now the patient is rendered hypercoagulable. Why? Because are you eliminating, with warfarin, those coagulation factors that are circulating within the blood? No, they're still remaining, correct? Because what have you done? What are you achieving by giving warfarin? You're inhibiting the new synthesis of coagulation factors from the liver. So therefore, if protein C becomes depleted rather rapidly, and you have these hypercoagulable or coag factors that are circulating, understand that you're then going to form thrombi in little blood vessels. And if this occurs, then what's going to happen? You're then going to create what's known as a skin necrosis type of situation. What other type of complication? Now, understand as well, though, those individuals that do have protein C deficiency are not necessarily always going to develop skin necrosis. Is there a possibility? Absolutely. But only 1/3 of those patients with a genetic disease of being protein C deficient actually develop skin necrosis. Other complications of warfarin. It is a teratogen. It's waging war upon the fetus. Other complications. Weeks later, there's a rare complication, weeks later, of developing with the warfarin what's known as cholesterol embolization. Who's our patient? 74-year-old male with atrial fibrillation receiving warfarin for how long? Weeks. 6 weeks to be exact, but weeks, not days, not 5 days later, not a week later, but weeks later. Thus, say that warfarin, with the rare complication of cholesterol embolization, now taking place down in the level of the foot and the digits, specifically vascular. What may then happen? You develop cholesterol embolization in those little digits. Is it possible that those digits in the foot may then result in lack of blood supply? Absolutely. And so therefore, with ischemia setting in, is there a possibility that the toes may then appear as being cyanotic? The answer to all of this is absolutely yes. Could be called blue toe syndrome. Or purple toe. This is not warfarin-induced skin necrosis. This is cholesterol embolization. So what about skin necrosis? Skin necrosis will be taking place days later. So if we're looking at skin necrosis, then understand that within a week you probably would find skin necrosis due to circulating coagulation factors. But with cholesterol embolization, you're talking about a rare complication weeks later, in which lack of blood supply, specifically to the foot and to the digits, may result in purple toe syndrome. Now that we have our answer, let's take a pause here. Our next discussion, we'll go into further details of pheochromocytoma, our other answer choice. And with pheochromocytoma, we must begin with the embryology of neurocrust type of pathologies.